with respect to developing new treatments for pain or new pharmacologic treatments for pain, there are some things that I've been paying close attention to that I'm curious to see how they pan out, such as the class of lipoxins or lipoxygenase with respect to a form of NSAIDs. The lipoxins seem to be something that play a role in signaling the healing phase of treatment rather than the active inflammatory stage of the treatment. But I don't think we know where that's going to go. We've seen some early clinical trials that predict that it might be effective, for example. But there's also some options, though, of maybe revisiting old molecules that I think would be pretty intriguing. For example, there was an NSAID that was pulled from the market, about a decade ago now, and largely because of the potential cardiac side effects. Well, having the stress of being in pain could have a potential cardiac stress as well. But I don't know that that cardiac risk was worse than any other medication in the class, but yet that was a very effective molecule with respect to providing pain control. I was part of a large clinical practice at the time that had multiple offices, and I think that pulling that medication off the market led to one of the most significant increases of opioid use because we had nothing else to replace that particular molecule with. But now that we have a better understanding of how that molecule behaved, who's to say we maybe shouldn't revisit it even with that black box warning, because there should be a patient population where I think that would be very effective for, and we already have the data to prove that. So why does it have to be the latest and greatest of something new? Why can't it be shielding something that's looking at something that's been used before? And I think there are other different things that we can do as well, because sometimes it's not the molecule itself, but the way that we deliver the molecule. Such as if you take a medication and you give someone like a bolus dose, it increases the dose, and you look at the certain amount of time that it's active in the bloodstream for, and then it sort of comes out. So you're essentially getting a roller coaster ride of dosing of your medication. But when we take some of the extended release technologies and maybe apply them to some of the molecules that are existing, maybe we can come up with a way of developing a more steady state dose of that medication that would have a better clinical outcome. Because we all know that, let's say, if you take even a regular NSAID, let's say over the counter, and if it's dosed at 3 times per day, it's going to be a lot more effective in managing that patient's pain than taking a single large dose 1 time a day. So, just kind of massaging the molecules that we have, at least we're working with a known, and we have a greater likelihood of having a successful outcome, because the downside that we have in coming up with an entirely new molecule that we can't predict is what's going to be the side effect and what's going to be the outcome of that, or what's going to be the downside of that. Because we all can find a patient population that we use for a controlled clinical situation, for a clinical trial, but once that medication gets out into the field and physicians, clinicians start using it, it never seems to get used quite the way the clinical trial had looked at it in. So by that time, we can't predict what it does, and we might end up with a whole new problem on our hands, which means that becomes the next TV commercial for, have you been injured by that medication? That's a critical one on new molecules, isn't it?